how the hell do you expect me to just take off all my shields, open up about these difficult experiences, and then go back home? And when they were taking the psychedelic substance, it helped them to open up, to lower their guard, and in a lot of cases to talk, but in some cases to really just process quietly. And the therapists were there to sort of just support them and were far less active in the MDMA group. The MDMA is almost like a third therapist in the room. It's different.
Today in the studio, we have Dr. Anna Harwood-Gross. She's a senior faculty member at Ariel University and a senior researcher at METIV Israel Psychotrauma Center. She's also the lead researcher of a new study looking at the efficacy of using psychedelic substances to treat soldiers with combat-related trauma. Dr. Harwood-Gross, thank you for being with us.
Thank you.
So let's just jump in with, could you tell me a little bit specifically about what your research is looking at and what it's found so far at this early stage?
So we're running a research trial looking at the effects of using MDMA to treat PTSD related to military trauma. So specifically for soldiers either still in Milawim, which is unfortunately the case with a lot of people in Israel, or soldiers discharged from Milawim, no longer in the army, but suffering from PTSD. We're looking at the effect of using a therapy paradigm which involves MDMA and a different therapy paradigm, which is very much based on the psychedelic protocol, but we call it SEIT. It stands for Somatic, Experiential, Acceptance-Based Intensive Trauma Therapy. And it uses the psychedelic paradigm, but adds a bit more psychotherapy and skills from our therapists. And we're looking at how it affects PTSD symptoms, but also the wider picture, how it impacts symptoms of moral injury, of functioning, of individual and social functioning, and looking at whether this is a valuable treatment option for those that have tried therapy in the past, it hasn't worked, and whether we can offer a second or third line treatment for them.
Mm-hmm. So over the last almost 3 years now, since October 7th, there have been thousands of soldiers who have been injured or, experienced some sort of psychological damage as a result of the wars we've been involved here. Can you speak a little bit as to how research into trauma has changed since October 7th?
So we started planning our research around 6 years ago. It took a long time to get going. You can imagine it's a very complicated protocol. It requires a lot of approvals, governmental, Ministry of Health, setting it up to get it started. And we were just about to get all the approvals. We got our ethics approval in the summer of 2023. We were about to get our first drug delivery in October 2023 when the war hit us. And we really had to stop at the beginning, and I think this was the case with many research sites. We didn't know that the war was going to continue. We didn't know how long things were going to last. I don't think anyone could imagine that 2.5 years later, we'd be sitting in very similar positions. So the immediate response was to stop everything. Who would have even thought to have psychedelic drugs when you have a risk of rockets falling on your head? Yeah. That's a paradigm that no one would even consider to be ethical. Mm-hmm. So we immediately halted our research. And I think it was the same with a lot of research sites. I'm finishing some research into prolonged exposure therapy, comparing it to somatic experiencing therapy. And it was clear to us that we couldn't be testing treatments under conditions of war. But I think as the war went on and we understood, and other researchers well understood that this was a new reality, we realized that Davka, the importance of testing treatments at a time of war is critical, because we're seeing an increase in PTSD just simply because of exposure. If you think a certain percentage of people who are exposed to trauma go on to develop PTSD, now the level of exposure is much higher. The risk of PTSD is understandably a lot higher. So we understood that there was a need, both in Israel to start the research project, but also abroad. We're a very Western-centric research community. Most research is carried out in America. Most of the money is used to, now not so much anymore, but used to come from America. And so a lot of these treatments that we use, for example, here in Israel, were tested in America. Now, the situation in America is very different to the situation even without war. Our culture is different, the way we approach psychotherapy. In America, it'd be unheard of for a psychologist to give her WhatsApp number. Mm-hmm. In Israel, that's like part of we're a close community, and that's part of the course here. also there's many places in the world that are kind of like us. We like to think we're this unique situation, but actually look at Russia and Ukraine, look at countries in Africa. Ongoing trauma and continuous traumatic stress exposure is part of the course for a lot of countries around the world. So actually, this unique situation where we're testing these treatments during a time of uncertainty is actually really important, not just for Israel, but for the rest of the world. And if we go back to my research and the kind of changes that we've made, I have to say we have a very strong clinical and research team that work together. So on the side of the research, got myself, and then on the side of the clinical, I work very closely with our clinical director, Dalia, Amit, Zivan. She really carries the mantle of what are the clinical needs, and I try and push what are the research needs. And together we're in this constant push and pull, and especially in regards to war, we have these dilemmas come up all the time. So for example, we have to do a lot of our treatments in a bomb shelter. Mm-hmm. We have to make sure there's a bomb shelter nearby. We have to consider when is the right setting clinically to be carrying out these treatments. If we're in a state of unrest, like with Iran, we do stop our treatments because it's not fair to put someone in such a delicate state, whether with the drug or without the drug, when there's a high chance of there being sirens, of being rocket attacks. And we also now included in our protocol really clear guidelines of when we can take someone onto our program and when we can't. So for example, it wasn't something we considered before, but whether someone is living in a permanent accommodation, when they became mefunim, they had to move because of Tel Aviv suddenly was under attack. And, you know, we've had patients even whose the area around them was deemed unlivable. And so it's very important when you're offering such an intensive psychotherapy that there's a level of stability outside the therapy room. When you're asking people to touch upon their most difficult traumas in their life, it's our responsibility to make sure when they leave the therapy room, there's some semblance of holding a sense of safety and a sense of care, that they don't feel that while in the therapy room, they're unpacking all their really traumatic memories, that they go out to a place that can hold their fragility. And we know that in both groups, the day after, the week after the intense sessions, they're in a more fragile state. Which maybe leads me into, I should maybe describe what therapy looks like for us.
Yeah. Well, first, actually, I want to kind of touch upon something you said earlier, in that, you know, Israel, we're in a regular state of war. And so if there's a place to, you know, research trauma, this is pretty much it. And, you know, but we're not the only place. You know, from Ukraine to Sudan to Nigeria, conflicts are raging around the world, where potentially research like this could have much broader implications outside of Israel. It's very unique, the research you're doing. Have you gotten any nibbles from, you know, researchers in other countries who maybe are interested in this kind of work?
Yeah, we're definitely in touch with other researchers in the field around. Like many researchers, we faced in Israel difficulties with collaboration. There's a lot of boycotts on collaborating with Israel. We've had collaborations that we thought were close, and then, you know, suddenly their university says no more collaborations with Israel, comes on their homepage, and they say we can't do these collaborations anymore. I would say, even if we're not allowed the official collaborations, there's researchers around the world that I've learned from. I think they're also leading the field. And I think that this joint sharing of knowledge is very, very important. But I also think within Israel, there's a growing field. There's not many countries like Israel that have such a large psychedelic research base. And I was just at a conference a week or two ago that my colleagues in Bar-Ilan organized. And it was wonderful. They just invited the key researchers of the clinical sites dealing with psychedelics around Israel to sit around a table and spend 8 or 9 hours discussing difficulties, insights, first findings. And that collegiality is something that I think is, you know, so important when you're trying to develop a field which is still relatively new.
But doesn't that strike you as, you know, kind of wild that you have research that could potentially be life-saving or like enormously helpful for people who are really struggling around the world, but because you're Israeli, like this potential source of, you know, this bomb, what it could be, is being boycotted. You know, I think maybe people don't think necessarily when they think of boycotts of Israel, they think of like the intellectual side of, or the medicine side.
Yeah, I think it's definitely a wider question than with psychedelics itself. I think it is important to highlight that there are some great researchers in the field that we're very much connected with. And, I really feel comfortable, especially Israelis abroad as well. There's some great researchers in the field of psychedelics, Lior Roseman, for one, who's an Israeli now at University of Exeter. I feel very comfortable sending him a WhatsApp saying, this is a dilemma that came up. Have you ever encountered it? Is it something have you dealt with it? But I also think there's a lot of unique questions that I feel that my colleague base in Israel are better suited to answer those questions. When are you starting up your research after Iran? How are you checking whether it's suitable or not suitable to, give people a psychedelic drug? And those are questions that I don't think there's no research sites that I'm aware of in the sort of third world, in other countries that are actively running. But, sometimes you never know of these things and you discover them and you make connections.
So let's get into that research. How it plays out, how it, your methods and that relationship between the psychedelic substances themselves with the psychotherapy.
Okay, so let me tell you a little bit how our therapy works and how it looks when you're a patient and you come to us. Mm-hmm. So first of all, when you apply to us, one of the first questions we're going to be asking you is, have you tried psychotherapy before? A lot of people experience the first bout of PTSD and panic. You suddenly feel like your world is being taken out from under your feet. You were functioning, you were working in high tech, you were, very successful. And these repeated bouts of reserve duty or the exposure to very difficult situations in military activity suddenly cause flashbacks, suddenly cause memories to just pop up when you're least expecting it. You stop going out. You start closing down your world. You have angry bursts at your wife, at your children, and you don't know what to do with it. It feels like you've become a different person. And your initial response is, this is so serious. I have to go to a therapy that's, really serious. And we would say, wait a second. We're very used to working with people with PTSD, and we know that there are a lot of treatments out there that are far less intensive than, weekly sessions, going to see a psychotherapist, either in prolonged exposure, EMDR. There's a lot of treatments out there for a first-line treatment for PTSD. And we'd say, that's really important for you to try a traditional weekly treatment first. Mm-hmm. And there's something about that remark that also says, we've seen this before, and the success rates are not great. But around for military trauma, we're looking at a success rate of around 40, sometimes a bit more, sometimes a bit less, 40% success rate. There's a benefit to trying regular therapy first, not just because you want to try the simpler option. You don't want to give someone morphine before you've given them paracetamol. Yep. Let's not run. But we also want people to have an experience of sitting with a therapist. Because when I'm going to tell you how our treatment looks, you're going to say, whoa, that's crazy. Mm-hmm. So we want people to have the experience of sitting 50 minutes, talking about their emotions, talking about their trauma. They might not be able to experience all their trauma and talk about it, but at least they've tried. Once they've had this sort of frontline treatment and they've tried the normal route of psychotherapy, then they're eligible to come to our trial. And we offer 2 branches of treatment. You can't choose which one. That's part of research. You're going to be assigned a treatment group. One group is offered treatment, which is with MDMA, a psychedelic substance, and one treatment is with more psychotherapy skills instead of the psychedelic substance. But in both treatments, they look the same in terms of the layout of the treatment. And how that looks is you'll first have 3 preparation sessions. So you've got 2 therapists, which again, another difference, and you can start to understand why I say you need an experience of therapy. Mm-hmm. Because already that situation where you're one person with 2 therapists is a bit different. Yeah. And we want you to get used to talking to a therapist first. So you'll come in and you'll have 2 therapists and you'll prepare for the journey that you have ahead. You'll think about what things help ground you, are resourceful for you, calm you. You might practice even going into the body, feeling those trauma experiences, getting a taste of what's ahead of you. Then you have this long 8-hour session.
Well,
That's why your response is generally other people's response, and also why we want people to have some experience of psychotherapy before they jump into these 8-hour long sessions.
Deep end.
Right. The room will be set up with a bed. There'll be music to encourage depth. The session will start with lighting a candle, setting aside your intentions for the session. We're very much based on intentionality. We'll discuss in those preparation sessions what parts of the trauma you want to focus on processing, what you want to change in your life, and what you want to be different. And then during those 8 hours, we'll slowly start to touch on those trauma experiences. But primarily, it's going to be led by a combination of the patient and their own sort of inner healing experience, and the psychotherapists who are trained to encourage that journey. And so throughout those 8 hours, we generally see in both groups, again, with the MDMA, it's more led by the substance, and in the SEEIT group, it's more led by the psychotherapy techniques. But in both the conditions, we're looking at kind of cycling through exposure to the trauma and moving away from it, because we're not spending 8 hours deep in your trauma experience. A, that would be very traumatic, and we'd be re-inducing the trauma. And B, that's not the right way of processing. We see that this sort of cyclic processing is really helpful for trauma, and we see it in a lot of different therapies. But the problem is in normal therapies, you have a 50-minute session, and then you sort of shut the door.
Yeah.
And here we have that opportunity to go deep into the trauma experience and stay with it without leaving the room. So then, after an 8-hour session, you'll stay overnight. In the MDMA group, you'll stay in the hospital setting, and in the SEEIT group, either in a hotel, but we're actually opening up a Zimmer that we built in the grounds of the hospital in Herzog Medical Center where we're based. And so you'll stay overnight with a Melavé Laila, which is like a nursing student, a nurse, a psychology student, someone who's not a therapist. The aim is not to do more therapy. The aim is to support you through your evening. And then the next day, you'll return to the room. You'll process what you went through on the 8-hour session with your 2 therapists. And then you'll have another 2 weekly integration sessions before you jump in and do another 8-hour session. And during the course of the 3-month treatment, you have 3 8-hour, we call them long sessions. And then after each one, there's 3 integration sessions.
Interesting. So what does success in treatment mean? And can you illustrate, like by example, what it looks like?
That's a good question, because I think success in treatment is twofold. The success that we can measure, and success that we can measure easily, is PTSD symptoms. And we generally are seeing early findings in both groups successful for reducing PTSD symptoms. That's something that we feel we're good at. We're still in early stages. We've not even reached our 20th patient yet. We're almost there, but we're getting there. But it's too early to make big, grand statements such as percentage success rate. I don't feel we're there yet, and it's too early to make grandiose comments. But in January, we're seeing PTSD symptoms going down. But it's a lot more than that. The people that are coming to us because they have severe PTSD symptoms, but they're also coming because they're in fractured marriages, or they're not able to have social connections. They're not able to function in the world. They're not able to work in the world. They're having these symptoms come up, and they're not able to deal with them. And there's a lot of guilt and shame and anger and betrayal. And these are sort of symptoms of what we term moral injury, that are sitting and not really moving. And so our goal in treatment, is to get rid of PTSD. Of course, we want to help people. We also want to learn to process and have a different relationship with those sensations and feelings that come up in relation to your military trauma. And oftentimes, that means not just looking at military trauma. That means looking about what happened before. That means building a timeline. That means processing a sense of who am I? Who was I? Who am I now? What's meaningful to me? And these are big questions and big philosophical questions that often are really difficult to capture in measurement. I think if we try and take a case in point, I'm not obviously going to give you the exact details of a patient who's been in our study, but I can definitely combine some details. So we had a patient who was an immigrant from France, who had come on a long Aliyah journey, had had difficulties, had settled in to Israel and formed an identity. This is me. This is what's important to me. But a big question that'd been throughout his life was the question of how manly am I? How good a man, father, husband would I be? And the army really shook that up. Those questions of masculinity came up specifically related to his trauma experience, related to mistakes maybe that he made, but also mistakes that the whole army as an institution made. Because when you're a single soldier in a big institution, it's not always possible to have a clear or clarity of we did the right thing. There's always going to be, even if it's objectively the right thing, there's always going to be questions of, was someone innocent hurt? Did I not shoot? Should I have shot? And these questions of both, who am I? What did I do? And what was done to me are questions that constantly come up. And then they come up and really dig the dagger in, especially at times of life changes. So, for example, becoming a father, or suddenly going to weddings with my friends, and I start to see, wow, everyone's having these relations, and I just can't imagine being in a relationship. I can't imagine trusting myself with women. And these questions are questions that are so hard to deal with in these very superficial, often, therapy settings. So this was a case that, for example, the person was so used to intellectualizing the problem. He understood his difficulty. He knew why it was there. He understood all the reasons and the deep psychological theories of why it happened. But actually his goal in therapy was to really be able to sit with those experiences, sit with the experience of shame, sit with the experience of hopelessness, sit with the experience of like not knowing and knowing that bad things could happen, and I'm able to sit with it. And some of the things that we saw help in this kind of therapy setting is the closeness of the therapist, the ability for them to really be there with the patient. And sometimes that involves, holding a hand. And in any other therapy setting, it's not talked about. And, we use things like holding a hand, putting a hand on a shoulder, but it's not protocoled in any other treatment. But in our therapies, both in the MDMA group and in the SEEIT group, we really think about those unique elements of the psychotherapy relationship that help someone process, and it's part of how we use the therapist in order to help the patient. So this was a patient specifically that I've kind of made up a few combinations of patients, but someone that actually went through SEEIT. And so during the course of those 3 sessions, they went deeper and deeper in their trauma experience related to those early questions of who am I, masculinity, and learned to sit with them. But we've also had patients in the MDMA group, for example, that were so closed. Every time they came to thinking about touching on their trauma experience, they said, how the hell do you expect me to just take off all my shields, open up about these difficult experiences, and then go back home? And when they were taking the psychedelic substance, it helped them to open up, to lower their guard, and in a lot of cases to talk, but in some cases to really just process quietly. And the therapists were there to sort of just support them, and were far less active in the MDMA group. So we see a big difference in how the therapists use their presence. In the SEEIT group, it's much more active. In the MDMA group, we say the MDMA is almost like a third therapist in the room. It's different.
So I want to get into the pairing between the drug and the therapy and how they come as a package deal. But first I want to ask, for a soldier who's been in Gaza or Lebanon and fighting Hamas, Hezbollah, or, like other groups, and, it's something that's scary, and you're living in an environment for a long time where, you could die, and you make tough choices, and maybe your vision of yourself is shaken to its core. How is it that MDA, aside from just lowering one's guard and making them more open, how is this helpful?
Okay, so there's a lot we don't know, and that's, I think, why we're doing our study. Sure. There's a lot of mechanisms that we presume. One of the mechanisms of MDMA is that it's often reported and, used colloquially that MDMA increases oxytocin, the love hormone of connection, increases a sense of empathy and need for other and connection with other. But when we did a recent meta-analysis to look at all the studies that measured oxytocin and oxytocin increase after taking MDMA, there was such a wide variety of results, and it wasn't even dependent on the dose. Oh. You'd think the more MDMA you have, the higher the oxytocin would go up. That would make sense if that was the lead mechanism of the drug. But we found it was all over the place. There was no correlation even between dosage and increase in oxytocin. So one of the things that we're doing in our study is we get our participants to chew a swab at 4 points during this long 8-hour session, whether they're with MDMA or without MDMA. And then we're testing their oxytocin levels to say, is this one of the ways it helps? Does the therapy also increase oxytocin? And can we isolate what's the drug and what's the therapy? And initial findings right now, we're seeing MDMA increases more the oxytocin pathway. But actually, when you look at the individual patients, I have a patient who his graphs look identical to MDMA. Was in the see it group.
Interesting.
I could show you all the graphs and I say, guess, is this MDMA or see it? And you wouldn't be able to guess some of them. So I think we have to have a lot more patients to actually be able to make any conclusions about this. But looking, and that's the benefit of sort of starting slowly, is you really look at each patient as a world in his own of understanding what's happening to him. We're being able to tease out these mechanisms. Another way the MDMA helps is also connecting to the inner experience. What we see is the MDMA seems to do a lot of the job of the therapist. The therapist still works very hard. 8 hours in a room with a patient, it's hard work. They come out sweating, they're exhausted. I mean, I've done it. I'm also a therapist in the trial. Yeah. It's hard work. But a lot of the work of the MDMA is that you see, and we're testing it. What I'm saying is an assumption. We're thinking that the MDMA increases the accessibility of those interoceptive experiences, the connection to the body. And I'm actually working with 3 wonderful master's students at Ariel University, and we're using sort of qualitative analysis to understand whether there are more interoceptive utterances in the MDMA group versus the see it group, and who's leading it. Is it the therapists that are leading it more in the see it group, or is it the patient leading it more in the MDMA group? It's going to be complicated research because there really isn't anything to base it on. But we're trying to understand and detangle what's going on. Right. I would say another really interesting study going on in Israel is one of my colleagues in Herzog Medical Center in Afula. So they're looking at the paradigm of groups and individuals. So my colleague, Dr. Ronen Saidi, who's at Herzog Medical Center, they're looking at the group versus individual paradigm and using other measures. So while we're sort of focusing more on the hormones, he's looking at more other physiological data. And there's points where we're hopefully collaborating, and there's points that each study site looks at something different. And I think that's really important as well. Everyone wants to understand, and everyone's rushing to try and understand, is this a treatment that can be rolled out across Israel and can really help the thousands of people that are not responding to treatment? I said at the beginning, 40% success rate. That's 60% that need more help. Right. So we're really racing fast. I would say a uniqueness of our trial is that we're really trying to understand also the psychotherapy. Yeah. Because a lot of people can't take psychedelic substances. Heart conditions, other history of psychiatric illnesses in the family, psychosis, etc. These are all non-indicators for using MDMA. Not everyone wants to take a psychedelic drug. Right. A lot of PTSD is about control. When your life goes out of control, you're very wary to give away control. And as much as you'd think, everyone comes to me and says, I just want to be in the MDMA group. Yeah. Some people come to me and say, I don't want to be in the MDMA group. I want to be in the see it group. I can't lose control to the level of taking a psychedelic substance. As I said, we can't choose. And at the end of the day, we only put people into the randomization that are willing to be in both groups. But it's important that we don't just focus all our energy, all our financial energy, just on the drug. We need to spread it out in order to make this a treatment that's accessible for everybody.
So let's talk a little bit about another element that makes your the treatment unique, in that the drug is paired with the psychotherapy, and if it were to be rolled out, that would be a prerequisite, is that it comes with the therapy. Can you talk a little bit about this pairing?
Yeah, it's a very difficult situation. I mean, you must have heard of the FDA rulings that said we're not willing yet to give an approval to MDMA because you can't really isolate the MDMA from the therapy, and therefore we can't give approval. Likewise, they said, the placebo groups, there's problems with them, there's problems with blinding. These are all things that, yes, they're true, but that's also inherently the paradigm. The paradigm is giving MDMA, a psychedelic substance that opens you up to make you more amenable to processing, to do the processing.
Yeah.
Because if we just open you up and we don't provide the psychological support for that processing, well, then you're just looking at a paradigm that's similar to the party drug.
Yeah.
People talk about a bad trip. In our case, there isn't really a bad trip because the purpose is to have those difficult experiences and to be guided through them. Now, if you try and take out and just give the drug, then I'm not sure what the purpose is, because there's other substances that are less reliant on the therapy element. But MDMA in particular, we don't see it as a drug that should be or would be used without the therapy paradigm.
Mm-hmm. So this would be something, if it gets rolled out, this would be a whole new method, a whole new way of rolling out a treatment that would be spearheaded here. Given that there's all this need in Israel and really around the world for more trauma treatment, do you what are the implications you see, the potential implications you see, even at this early stage in the research?
Right. So we're working also with Karen Sarfati from MAPS Israel, who's really spearheading the work on, I wouldn't say legislation, but looking at how to integrate MDMA-assisted therapy within the Ministry of Health and within a wider rollout for Israel. But I think the implications of moving forward with this and offering both paradigms, both the intensive psychotherapy paradigm and also the psychotherapy with psychedelic assistance, first and foremost offer hope. Mm-hmm. We have a lot of patients who come to us who, had traumas from one of the Lebanon wars, the Yom Kippur War, really old traumas that have suffered for many, many years, and had kind of lost hope in the system, had kind of lost hope as they tried all the standard therapies. They'd done the EMDR, the PE, the CPT, they'd done all those therapy paradigms and they hadn't got help and they'd felt a bit lost. So I think primarily this offers hope. Mm-hmm. I think that it also offers a paradigm that once we understand more, we can be more flexible with it. The current paradigm is not an economically sound paradigm.
Yeah.
If you think about two therapists, and we're talking about highly trained therapists, therapists with trauma experience, psychedelic experience, somatic experiencing, this is very expensive to train them.
8 hours.
8 hours, 3 times. It's a paradigm that's not going to stand the test of time.
Right.
And once we get approvals to do this, it's not going to be financially viable. So what we need to do is then look into how we can change the paradigm and what bits of the paradigm are necessary and how we can break it up. And one of the things that we're doing, and I'm hopefully putting in grants for and trying to get this moving, and I really hope we're going to get funding for this, is to start to study the use of the drug within a general psychotherapy setting. Mm-hmm. So with the way the current paradigm works is you have these big, intensive 3-month bursts of treatment. Mm-hmm. And then maybe you return to your therapist or you find a new therapist or you process, you have a lot of grief at the end of it. You reduce your PTSD symptoms, but then you're like, wow, I lost 10 years of my life where I was suffering with PTSD.
Yeah.
It's not a quick fix. Most of the patients that come to us don't leave and never go to therapy again. They might go to yoga or drama groups or other therapeutic mechanisms, but they generally just don't go back to life with no support. And so what I really want to look at and what I'm trying to get the money to study is how we can take this paradigm and integrate it with the community. Mm-hmm. The general psychotherapy service, which is offered in the Kupa, is offered in hospitals, is offered privately. You pay too much money, but you pay to go see a private therapist.
Yeah.
how can we integrate this better? How can it be part of a usable treatment that's also not bound by these 3-month intensive protocols?
So is getting the funding for this the only roadblock you're facing in rolling this forward?
I mean, I think with anything you need to apply for more ethics approval, but
Yeah.
that's generally less of a problem because we're not looking at giving more drug, we're in fact giving less. I think a lot of funding issues are that in order to do this properly, we need to start with small numbers. We need to work very carefully and methodically. And unfortunately, it sits somewhere between, philanthropic funding, which just wants to treat as many people as possible in the widest manner and get it out to the most people, and sort of scientific funding, which works very slowly and really works on very small mechanisms. And we're sitting again, just like with the FDA, there's this unique paradigm of drug and therapy. Also here, we're sitting between philanthropy and research, science funding, and we're navigating a new field.
Yeah. Well, thank you so much for coming, and I really appreciate the talk.
My pleasure.